طيب بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين سيدنا وحبيبنا ونبينا محمد. Today we are going to talk about the standardized mammographic reporting, passing through the previously described lexicons, abnormalities or the abnormalities in the ACR lexicons. I will try to review some of which while we are doing or we are discussing the structured mammographic reporting. Okay. The American College of Radiology in 1992 developed the reporting system, the BIRAD lexicons for mammography. And the latest update is the 5th edition 2013. So you know what is BIRAD, is abbreviation for breast imaging reporting and data system. And this is a common language define uniform descriptive terminology or the lexicons used to describe findings in mammography as well as MRI and ultrasound breast. From different institutions is designated to standardize breast imaging reporting. This will reduce confusion in interpretations and facilitate outcome monitoring. All other previously used systems were abundant. Why? Because unlike BIRAD, lacking quantification and evidence-based, and the BIRAD reporting system is designed to provide an organized approach to image interpretation and reporting, having standard way of reporting mammographic lets the doctors use the same word and term that ensure better follow-up of suspicious findings and also help in giving a quality assurance, helping in reporting quality assessment. So what is a lexicons? The lexicons is a book containing a clearly defined vocabulary list used to a person in language or in a branch on on knowledge, okay, to ensure that when group of people use the same term, the terms means the same thing for every individual person in the group. So, as you know, the mammographic lexicons, okay, including the breast compositions, certain descriptions for descriptions for breast compositions, and describing certain type of abnormalities seen on mammography, which are the major four abnormality, including the mass, asymmetry, architectural distortion, calcification, as well as associated feature and special findings, special cases. And for each these abnormality described by certain or having certain descriptors. See, when use it, everyone anywhere in the world will understand you are talking about specific lesions, or the lesions definitely you are describing is going to be in a certain category, having a certain management. Okay, so the report organization, it should be concise and structured, containing first descriptions for indication of the study, then describe breast composition from A to D, and clear description of important findings, as we described before, including mass, asymmetry, calcification, distortion, or associated or associated findings, and then compare it with previous study to conclude into final assessment category, accordingly give management recommendation, and in case of unsuspected finding, we have to communicate with the referring physicians. So, starting by the clinical indications, Mammogram performed in two settings, as you know, either screening for high-risk women or for average risk women after age of 40 or in a diagnostic setting. And for patient management purposes, breast disease is classified into clinical or symptomatic symptomatic cases versus screening detected lesion cases. Okay, so our report should start it by the clinical information or the indication for the study, provide a brief description for that indications, which may be screening for asymptomatic women or diagnostic mammography for certain indications. What are the indications for the mammographic diagnostic mammography? Do you know? When we do a diagnostic mammography, what are the scenarios for which
Breast lumps.
diagnostic mammography is performed?
Breast lumps.
Okay, clinical abnormality or symptoms. We have to recommend to repeat this view, okay, and report it as BARAT 0. If you look for this image, you see, looking for the technique, definitely these are CC view for the same patients when the breast is pulled, you see, adequately pulled, and the nipple seen here in profile, we could depict the posterior cancer missed in the inadequate CC view on the left side. And if the patient has implant, we have to remember to do both view, the implant in place and implant displaced view, or the standard view, while the implant as it is in the normal place, then the technicians pushing the implant to inside, see, and pull the breast parenchyma, like in this view, so we could appreciate most of the parenchyma, or we could see most of the parenchyma away from the implant to see for any hidden lesions. And this should be stated in the mammography report. And if you use computer-aided detections for the mammographic evaluation, is also being stated in the report. Okay. After that, we make sure we have a good quality image. Then we have to comment on the breast compositions. And previously, you see in the previous editions, they used to use the percentage volume of the fibroglandular parenchyma, you see, to describe the breast density starting by SCR1 when the fibroglandular breast is less than 25%, reflecting entirely fatty breast. And when the fibroglandular parenchyma is 25 to 50, scattered into the breast, within the breast, they describe it as SCR2 or scattered fibroglandular parenchyma. And when it is 50 to 75%, it was described as heterogeneously dense or SCR3. And if it is more than that, it will be extremely dense or SCR4. At that time, these are my cases. The reason I brought these cases because it was difficult to me to apply for these cases, or some of these cases, I found difficulty to apply certain SCR breast density. If you look for this, yes, I might put SCR2, the breast parenchyma between 25 to 50, and it's scattered into the breast, and I could see through this, and the sensitivity is reasonably low. But same percentage of the parenchyma here, You see, it is compact. It is coalesced in a more denser, while the volume or percentage of the parenchyma is more or less the same. And if you look for this, also the same, but it is a little bit more denser. And for this, it is even less. It is less. It is about 10% or even less, but it is dense and complex, and it can obscure underlying lesions. And for this also, it is less than 25 even, but it is a compact disc in the upper outer breast. And definitely, if there is non-calcified lesions, can be hidden by this dense parenchyma. And this already, there is a lesion here. I could appreciate it on ultrasound. So at that time, I used to write, you see, to put a phrase or a sentence. I mentioned that in spite, the parenchyma within this breast is about 25 to 50 or even less than 50, but it is located, it's seen as a dense or a compact or coalescent dense located in the upper outer or located that might obscure lesions. And if you look for this one, it's also, it's heterogeneously, it's supposed to be heterogeneously dense between 50 to 75. But look for this, the parenchyma, the attenuation, the density of the parenchyma or the attenuation effect of the parenchyma is less. It is less dense than the same amount here. And for this, even it is less than this, but it is patchy in certain area. It is more dense and it is more complex. It is more complex. So there are many rather than just the volume of the percentage or volume of the parenchyma within the breast. Again, these also my cases. You see, if you look here, this is, it's supposed to be SER2 at that time, but definitely now, this I will report it as SERC corresponding to SER3, while this is still, it will be SER B or SER2. Why? More or less same amount or same percentage of the parenchyma, but this is heterogeneously dense, while this is scattered. But it depends for many factors. And if you look, these also my cases, you see, look for the amount of the parenchyma. This is almost occupying the whole breast with paucity of the fat. Look for the subcutaneous fat, erythromammary fat. There is even lack of the fat or the very thin layer of fat. There is paucity of the fat, while the fatty layer here is very thick, but still the amount of the parenchyma or fibroglandular tissue is much less compared to this one. But if you look for the area occupied by fibroglandular parenchyma itself, the smaller one is more denser or giving more attenuations or more density, more attenuation for the X-ray and increasing density than the larger one. See? So previously, it was SER3 and this is SER4 by the percentage of the parenchyma. But according to density and masking effect of the lesions, now both are reporting as SERD. Again, these all are my cases. I used to present it in the lectures even before the 5th editions, reflecting this problem. And if you look here, the amount of the parenchyma occupying the same area, but there is good fat or good amount of fat within the parenchyma, see, make it less dense and better visualizations through it, while this is not. And the same for the other examples. Okay, so it is not uncommon for some areas in such breast to be relatively dense, while the others are primarily fatty. And a few coalescent area of dense tissue may be present in breast with as little as 10%, okay, dense tissue, while primarily fatty, okay, areas might be seen within a breast having more than 90% dense tissue. When this occurs, according to recent, okay, latest edition recommendations, after they observed, the radiologist, breast radiologist, having all these observations, they describe this and they recommend a second sentence, okay, to for a second sentence to describe the locations of the denser tissue, so as to reflect for the clinicians and to let him aware that there is this area might obscure an uncalcified small lesions, okay? And the suggested wording for that recently in the latest editions include the dense tissue is located anteriorly in both breast or in upper outer quadrant or in certain area, while the remaining breast is fatty, or it is located anteriorly and the posterior part of the breast is mostly fatty, as they described recently. And they are giving these examples. You see, if you look, same, this is the ACR example as I have shown in my cases. You see, the amount of the parenchyma here or the percentage is more than 50, while here is less than 50. Suppose this historically to be ACR2, while this is to be ACR3. But if you look for the parenchyma within these certain areas, this is heterogeneously dense, and this is heterogeneously dense, regardless of the amount or the percentage of the parenchyma. So currently, for both, we have to report it as composition C. You see? Do you got it? Okay. So in the latest editions, the percentage is discouraged because in individual cases, it is more important to take into account the chance that the mass can be obscured by fibroglandular parenchyma than the percentage of breast density as an indicator for breast cancer risk. Okay. Also important point, they change or they change the assignment or the assignment terminology from the 1, 2, 3 previously, so as not to confuse with the the number of the assessment category. You know, the assessment category from 0 to 6. When you say breast density from 1 to 4, it might get confused with the categories assessment. So in the latest editions, they change this number into letters. Instead of being the density 1, 2, 3, becoming A, B, C, and D. See, 1 is corresponding to A and 4 corresponding to D. And as you know, the breast composition is fat, gland, and connective tissue or fibrous tissue. And the fat, you see, is not much absorbing the X-ray, so it appears as black, while the fibroglandular tissue absorbing the X-ray, that is why it results in opaque or whitish appearance on mammography. So the more fibroglandular, the more attenuation and the more opaque. And these here are the 4 categories, A, B, C, and D, you see? And this is definitely the more fatty, no attenuation of the X-ray, and it is the most sensitive type of mammography unless the lesion is occur outside the field of mammography. Otherwise, is the highest sensitivity for the study. And the sensitivity definitely is going to decrease after in B, C, and it will be least in D. The B, previously or historically, it was scattered fibroglandular densities, but at current described as scattered areas of fibroglandular density. The density reflecting the attenuation of the X-ray. And this is, as before, is heterogeneously dense, and this is extremely dense, which having the least sensitivity. And usually, and this is subjective, you see, reflecting or assessed by visual estimation of the radiologist. Though currently they have some automated approach, but mainly we are using this composition based on visual estimations of the radiologist, and it depends on the experience of the radiologist. And definitely there are some inter-observer variations, you see, especially between the two closed type of density, between entirely fatty and scattered, or scattered and heterogeneously dense, or between heterogeneously dense and extremely dense. You might find one radiologist reported like this and the others. And they used to use the sky, okay, as to reflect the mammographic density. If you look here, this is definitely the clear sky, like a fatty breast, and with some clouds and more clouds, and almost the sky is full of clouds like this dense breast. And the percentage of women having extremely fatty breast found to be about 10%, and those having extremely dense is 10%, while those in the middle representing 40%. So half of the women having high density breast and have a better sensitive and a relatively fatty breast. Okay, if you look here, definitely this white spot is easy seen in contrast the black fatty breast, while in the dense breast, we need to do an effort to look for this area of white spot on background of white parenchyma. Again, this is definitely, this is small cancer easy be visualized, appreciated in this fatty breast, like in this clear sky, while definitely in this cloudy sky, even a full-size moon it will be obscured by the cloud as in this dense breast. But if the lady is lucky, okay, the cancer can be present in the area, the fatty area, in the background of this extremely dense breast, like this moon is seen in the clearer part of the sky, in the clearer part of this cloudy sky. Can you see any abnormality in this mammogram? This is our nurse, has 55-year-old, having left, sorry, not right, having a palpable abnormality or pain for 3 years. Can you appreciate any abnormality in this dense breast?
I think there is asymmetric density noted at the medial side, posterior breast.
Here or here?
At
or
the medial.
Here?
Medial.
Here?
No, anterior. Just anterior. Here? Yes, yes.
Excellent, well done. Yes. So Look, this sizable lesion obscured in this dense breast. Yes, it appears as some asymmetry here, yeah, but not is difficult, very difficult to be appreciated. Not everybody could visualize this area so easy. The most dense breasts, the largest the lesions, or the denser the breast, the larger the lesion or the lesions that may be obscured. Can you see any abnormality in this mammogram? Or you pass it as a normal?
The rounded area in the middle
if I tell
zone.
you asymptomatic, if I tell you she's asymptomatic lady, you will pass it?
Rounded area in the middle zone.
Middle zone? Here?
No, anterior.
Here?
Upper.
Here?
Above
Here?
it. More above.
Here?
Yeah.
If I'll tell you, I did not bring the other mammogram, the contralateral breast, but if it is the same in the contralateral breast,
Then it is
yes,
normal.
you might say this area relatively denser for the remaining of the breast, but I might tell you this area is also denser. But you are right, at the same location, there was these lesions. But even retrospectively, could you explain if I'll tell you this lesions is down? It's difficult, even it is heterogeneously dense, but definitely this is even retrospectively is difficult to be appreciated in this dense mammography. These are my cases. Okay, so mammogram of dense breast, okay, with a higher proportion of fibroglandular tissue can obscure sign of breast cancer. And on screen film as well as fulfilled digital mammography, about half of the cases of breast cancer can be passed and detected. As well, the dense breast considered to be moderate risk for breast cancers. Mammogram can detect breast cancer with variable sensitivity ranging from 63 to 98%, but can be as low as 30% in a dense breast, as you know. Okay. If one lady asks you, if I have dense breast, do I still need a mammogram? Do I still need a mammogram or a mammography study?
Yes.
Suhair?
Yes.
Yes. Why? Yes.
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 Because there is some situation like microcalcification detected only in mammography.
Yes. Most breast cancer can be seen on mammogram, even in women who have dense breast. And as you know, mammography is the only modality proven to reduce mortality from breast cancer up to date. So it's still important to get regular mammogram that can help save a woman's life. Okay, if you look for this dense mammogram, what is the abnormality?
Pectoralis.
The abnormality, which side, right or left?
Left.
Left. Here?
Yes.
Yes, quickly. Yes, left.
Inferior, inner.
Inner, inferior, excellent. Yes, the mammography here, this is multicentric invasive ductal carcinoma associated with high-grade BCIS. You see, it's seen, it's diagnosed in this dense mammography. And if you look here, this is regular screening mammography demonstrate what? Developing asymmetry in a case of early detected invasive cancer, and the patient, she's lucky. Why? As the cancer is evolving in a fatty area. In the fatty area, like this small moon coming in the clear area in this cloudy sky. Definitely, if it's coming here, you could not visualize it, you could not see it. But being seen in the clearer part of the sky, in a background of black, is clearly appreciated, like in this small developing asymmetry coming in the background area of fat. So it's easy, appreciated, and detected early. And that is why even in a dense breast, still she needs to do mammography. And nowadays, the use of tomosynthesis 3D has been increasingly incorporated for both screening and diagnostic purposes to overcome limitations of dense mammography and improving breast cancer detection, as seen in these cases. If you look for this, you see, look for this mammography and the 3D. If you compare it even here, it's really difficult to be appreciated, as in this example, also appreciated in the 3D, even retrospectively. Here, barely seen in the 2D, but more appreciated in the 3D, and the same for this example. However, as I understand from one of the experts, a breast radiologist, she said that the 3D is working in type C, but doesn't work much or helpful in this type of extremely dense breast. Okay. Then let us go for mammographic abnormality. And after we describe the indications and the compositions, we have to look for any mammographic abnormality to be described in our reporting. And as you know, we described before, the lexicon include main abnormality, which are mass asymmetry calcification and architectural distortions, as well as the associated features, and then describe their locations and size and so on. And there are special cases. So starting by the mass. Okay, can you remind me what is a mass? Do you remember what is a mass? Those who attend the lecture of mass?
Yes.
Huh?
The 3D space occupying lesion that is seen in two different views, and it has conspicuity and convex border.
Excellent, well done. Yes, a mass is a space occupying lesion, three-dimensional, that giving a mass effect into adjacent structures. It has a consistent shape into orthogonal view, having partial or complete convex outward borders. And dense at the center, and okay, and if potential mass seen in a single projection, we call it as asymmetry until fulfill the criteria of a mass to be described. Okay, so if we have a mass, we have three descriptors, which are, as we mentioned, density and morphology, including shape and margins. Shape and margins. Regarding the shape, we have regular, rounded, and oval, as well as irregular. So, oval, birat, it will be birat.
Virus
you know,
Virus
for all descriptors, we have positive predictive value. You see, that will help us when we go for assessment. You see, when we go, that is why I tried to review for you the descriptors of abnormalities, because when we go to assessment categories, at least we should know each lesions by certain descriptors having a positive predictive value. We could assess, or we could assign it, or we could code it for certain categories. So oval, this oval, so it's supposed to be
3.
3. Excellent. This is bara 3. And this is rounded. It will be quickly. Still we have
Also 3.
3. Excellent. So oval and regular shape, oval, and rounded, it will be bara 3. While irregular, it will be bara
4.
Yeah,
4.
4 or 5.
Regular 4.
For what? Yes, you're right. 4.
4C.
Excellent. Excellent.
4B.
It is 4C. It is a 4C. So if you have an irregular mass without any associated features, it will be BIRAT 4C. Put it in your mind. Okay, so this is BIRAT 4C. When we go for the margins, it will be circumscribed, BIRAT 3. Obscured, BIRAT 3. Indistinct, BIRAT
4C.
Are you sure? Indistinct.
No. Indistinct 4B. 4B.
4B. It is 4B.
45%.
It is 44%. Microlobulated,
4C.
microlobulated.
It's 4B.
Who said 4B?
Sarah.
Yes, excellent. 4B. Is it more suspicious than or less suspicious than indistinct? Which
It was
one is more suspicious,
67.
microlobulated or indistinct?
Microlobulated, it was 60 something percent.
If it is 60 something, it will be 4C.
So
Sarah, she said 4B. She's correct. It is 4B. So
less, yes.
yes, it is
But
only 17. Only 17.
Yes.
Okay. So the indistinct is more suspicious than microlobulated. And what about the speculated? Hint. Speculated
Highly
is BIRAT.
suspicious.
Is BIRAT.
No, 5 or 4C.
Highly
Who said 5?
suspicious.
Who said 5?
Nahidi.
Yes, you are right. It is 5. It is 96. This is the only single characters, you see, giving BIRAT 5. The only single characters giving BIRAT 5. Usually not described BIRAT 5 or coded BIRAT 5 by single character, except for the speculated mass. It has a very high positive predictive value. Okay. What is the difference between the margins in 1 and 2? What is the difference?
In one, the margins are indistinct.
Excellent.
While
Medina?
in 2 is yes.
Obscured. Obscured.
While in 2 is partially obscured.
Excellent. Who described? Who's talking?
Medina.
Excellent, Medina. Excellent, Medina. 10 by 10. Excellent.
Yes.
Okay. So what about this 1.5%? 1.4% of these circumscribed group are malignant. As you know, going from circumscribed toward my indistinct microlobulated to speculated, going toward the higher, okay, suspicions, level of suspicions. But if you look here, this is speculated mass is invasive cancer, while even this circumscribed equal density are also invasive cancer. See? But we have to be cautious not to label just being circumscribed as benign lesions without doing a workup and make sure on mammography, ultrasound, and history, and everything is pointing toward benignity. What are the differential diagnoses for the 1.4% of circumscribed masses, malignant masses? What are the malignant masses included in this 1.5%? What are the differential
Mucinous.
diagnoses? Mucinous,
Mucinous
excellent.
carcinoma.
Mucinous cancer. Quickly, you have to just 1, 2, 3, 4, 5. Mucinous.
Lobular carcinoma.
Hint,
Yes.
I want to pinch your ear. Lobular, ya hint. Lobular, ya hint.
Intraductal papilloma.
We said malignant. We said malignant. The differential diagnosis for malignant circumscribed. We have 1.4%. Papillary carcinoma. Yes, mucinous, papillary. What else?
Medullary carcinoma.
Medullary, excellent. Medullary. What else? Yes, mucinous, medullary, papillary. Then remaining 3. Quickly. Still we have a lot to be discussed. Keloides, metastasis, high-grade invasive ductal carcinoma. Okay, and we said the high-grade invasive ductal carcinoma, there is no time. It is rapid proliferating cancer with concentric growth, no time to invade. It will appear as oval or rounded mass, circumscribed mass. Okay. Regarding the density, as you know, we have either radiodense or mixed fat containing mass. Mixed fat containing mass, we'll talk later, is benign, while the radio opaque is either low, equal, or high density. High density having positive predictive value up to 70%. So with a high density circumscribed mass, just palpable, just you might go for BIRAT 4C. While equal density is BIRAT 4B, and the cancer is extremely low, but not exclusive from low density. Fat containing mass is mostly benign or almost always benign. These are examples of hamartoma with different amount of fat. It is a mass We will not call it as a mass, we will call it
developing. What?
why developing hint?
معلش أنا الصوت قطع مني فترة بس ما عارفة كان في شنو. معلش قطعت من النت فترة ما عارفة السؤال كان شنو.
لا النت قطع من عندي أنا. النت
الصوت
giving
قطع
me
من عندي.
الصوت كان قطع أيوة.
النت give me unstable. So this I said it is seen, it is not, I cannot say this is a mass because I could not appreciate it in two orthogonal view. So I will call it
asymmetry.
Asymmetry. I'll call it asymmetry. Okay? And this one I'll call it
architectural distortion.
Okay. Regarding but the main abnormality is
Asymmetry.
Asymmetry. Which type of asymmetry?
This is
which type? What are the type of asymmetry?
Focal asymmetry, global focal asymmetry,
global
asymmetry, developing asymmetry.
Type. Okay, this which type?
This is global asymmetry at the right breast.
Global. This is global. Right or left?
Right breast.
Distortion in the right, it is on the left. The asymmetry is on the left, you see? And it is a global asymmetry on the left side. The area of density is on the left side. Added density with distortion and with nibble retractions. And what about this? We call it this type
focal asymmetry.
Focal asymmetry.
And this one
developing.
When you look here, this is
developing asymmetry.
This is developing asymmetry. Okay, so we have the commonest is the asymmetry, the one seen in one mammogram, and the least is the developing asymmetry. And usually, you see the asymmetry up more than 80% represent summation artifacts or of normal breast tissue. But still the asymmetry, okay, if it is persist, can represent or can be seen in up to 10.3%, okay, of screening detected cases. Can see malignancy in up to 10%. So it will be 10.3%. So if it persists, the asymmetry, if it persists, it will be Bayrat 4B. It will be Bayrat 4B. And if it is early detected, the likelihood of malignancy is 1.8. So it will be Bayrat 3. If you have seen asymmetry at the beginning, it will be Bayrat 3. If it persists, it will be upgraded to Bayrat 4B. Okay? For global asymmetry, usually it is normal variant Bayrat 2 in general. But if it is palpable or associated with additional findings like distortions, like suspicious calcification, can be upgraded to 4 or even 5. Focal asymmetry, the asymmetry simulating the mass. However, it is lacking the full criteria of the mass, the convex outward border, and the central increased density or higher density at the center. But the likelihood of malignancy is even less than the asymmetry, is less than 1%, but it is more than 0. So it will be Bayrat 3. If you have at initial diagnosis, you have focal asymmetry, it will be Bayrat 3. Developing asymmetry is the least common, but the probability of malignancy or the positive predictive value is up to 26.7. From 12 to 26. So it will be BIRAT 4B from the beginning. If you have an initial diagnosis, there is a developing asymmetry, it will be BIRAT 4B. Okay, is it clear now? Okay. Here you can see example for Ramas versus asymmetry. If you look here, the center is denser and the border, outward border is convex and occupying lesions. If you have seen the other view, you see, you'll see it in both orthogonal views, a consistent shape. While this is the asymmetry, looks like a mass, but the center is not dense and lacking persistent shape in the two view and lacking the convex border. It has a concave borders. Okay, finish the asymmetry, going to calcifications. And as you know, the calcification by morphology, we have 9 groups, typically benign calcifications from skin, milk of calcium, rod, rim calcification, bopom, dystrophic, vascular, round, punctate, or sutures. Round and punctate now are joined in one group, and the 9th one is a suture calcification. These are typically benign calcification. If it is not typically benign calcification by morphology, then it will be suspicious type of morphology, including the coarse heterogeneous, amorphous, and fine pleomorphic. The 3 are representing BIRAT 4B with increasing positive predictive value. The list is coarse heterogeneous, and then amorphous, and then fine pleomorphic, more suspicious within BIRAT 4B, while the fine linear branching represents BIRAT 4C with a higher positive predictive value. This is the coarse heterogeneous, and these are amorphic, pleomorphic, and this is branching. This is fine linear and fine linear branching. This is regarding the morphology. Then we have to look for the distributions of this type of suspicious morphology. Starting by diffuse, usually diffuse is BIRAT 2. Then going to regional, positive predictive value 26, representing BIRAT 4B, and group also representing 4B. Group is a little bit more suspicious than regional, and the most suspicious are linear and segmental. Linear and segmental are BIRAT 4C regardless of the morphology. Any type of calcification in linear or segmental distribution, you have to put it BIRAT 4C. But if it is regional or group, okay, then you have to look for the morphology. If it is in BIRAT 4B, it will be still BIRAT 4B. But if it is linear branching, okay, morphology in group or regional, it will be upgraded, okay, to BIRAT 4C because of the most suspicious morphology. Okay, going to architectural distortion. As you know, the architectural distortion, it means the normal parenchyma without presence of underlying mass being distorted. What is the meaning of being distorted? Okay, the contour of the parenchyma is deformed, either retracted, tethered, angulated, getting straight, or associated with spicules, long spicules or lines, okay, pointing to a center which is loosened, or combination of contour deformity or contour abnormality along with speculated lines. Okay, we said again, the distortion is, the main distortion is either contour deformity And this contour, it can be at the parenchymal fat interface, the contour of fat parenchymal, but sometimes, okay, within the parenchyma itself, the connective tissue within, inside the parenchyma itself, either tethered, retracted, angulated, bulging, okay, and all these deformity, contour deformity alone, or with speculation, or a speculation alone. You have long spicule pointing to a lucent center. If you have history of trauma, or history of tissue, tissue biopsy or surgery or trauma, yes, it can explain. If you have no history of this, then you have to make it suspicious, or to raise a suspicion for breast malignancy. And here, this is a difference between a speculated mass with a dense center. You see a convex border, while this is the center of architectural distortion is usually pointing to more lucent. These are spicules. Some are associated with asymmetry, but the central part is less dense than the periphery. So the associated features are also important, and we'll go through these associated features related to the skin thickening, parenchymal thickening, trabeculation of the connective tissue within the breast and Cooper ligaments, nipple changes, retractions, thickenings, and lymph nodes, and associated calcification, associated architectural distortions, all these having a clinical significance. And when it is present, it might upgrade the lesions, especially if combinations of abnormalities present in the same mammogram. It will upgrade the lesions, might be from 4 to 5 category assessment. What about this mammogram? Can you see the abnormality here?
In the left breast, there is diffuse skin thickening associated with global asymmetry and thickening of trabeculae. With
excellent.
This large macro calcification is benign calcification, most likely representing involuted fibroadenoma, which is bilateral.
Okay, So your assessment, it will be BIRAT?
This is BIRAT 4C.
4C, it's okay.
Yes.
So when you see an abnormality like this, you have to look for any more suspicious lesion within the breast.
There is an area of suspicious microcalcification at the.
You have to look thoroughly where?
At the upper part of the breast, middle.
Yes, if you have seen edema, if you have seen this trabecular thickening and skin edema, look carefully within the breast for any suspicious calcification, any asymmetry, any masses. Yes, look here. What about this? There is indistinct mass of equal density.
Yes.
But even if it is a higher density, but because of the edema, masking by the edema, and associated with most suspicious type of
calcification, this
is the linear type of calcification. So it will be BIRAT.
This is 4C.
Why 4C? Why 4C? If you have seen this type of calcification alone, if you see this type of calcification, the calcification associated with indistinct mass and diffuse edema, it will be BIRAT 5. Now 5. You have multiple, okay, abnormalities, stacking of abnormalities. So this is a dense, indistinct, irregular mass with calcifications. So it will be BIRAT 5. And even there is some speculations here. It is a BIRAT 5. And look here, This is a ductal density with suspicious type of calcification representing DCIS component of invasive cancer. And these architectural distortions associated with calcification or calcification associated with architectural distortions, also linear type, so it will be BIRAT. Will be BIRAT
5.
It is BIRAT 5. It is BIRAT 5. There is asymmetry, focal asymmetry with associated architectural distortion and linear type of microcalcifications. So it will be BIRAT 5. It is my case, it was invasive ductal carcinoma. And this is trabecular thickening. If you look here, this is so circumscribed mass, but there is skin and breast edema. So it will be BIRAT
5 also.
No. Here I will make it BIRAT 4C. Why? Because it can be an abscess.
Oh,
It can be
okay.
an abscess. I'm not sure. It
Okay.
can be an abscess. See, if it depends on ultrasound. After ultrasound, I might upgrade or downgrade it. But here I will say, but in the other, in this I could not see underlying mass. It will be BIRAT 4C. There is edema. I need to do ultrasound and even go further looking for any lesions here associated with this edema. Because sometimes it can be inflammatory carcinoma, see, and you know that the lesion in inflammatory carcinoma are small interconnecting nodules, might not be appreciated on mammography, and even sometimes on ultrasound not be well appreciated, only presenting by the edema. On MRI might help to find this type of small lesions on inflammatory cancer, but it can be for systemic cause. See, the edema itself. So it will be, since I could not see something, lesions within the breast, it will be BIRAT 4C. But this is BIRAT 5 because there is a mass, irregular mass, hyperdense mass, along with edema. It is nipple retraction, and this it is BIRAT 5. And this is skin changes. This is skin tethering. You see, and retraction in speculated mass. This is BIRAT 5. This is small hyperdense lesions, and this is focal thickening. This it was ulcer, and there is no underlying mass, but that was malignant ulcers. You see, and here there is a lesions with skin thickening and retractions, and there is trabecular thickening adjacently. This it will be BIRAT 4C, unless I have seen the ultrasound upgrading or downgrading. Why? Because periductal mastitis can give me the same appearance, so I cannot go for 5 directly. Nipple changes or nipple thickening and retractions associated with irregular hyperdense mass, you see, BIRAT 5, and this is thickening and retractions, and there is edema here also, you see, and this is in a case of breast cancer again, while this it was a papilloma. See, look for the retractions, how it retract, and these all are small papilloma. This is large papilloma, while this nipple retractions without associated lesions in a case of chronic ductectasia. Okay, this is malignant axillary lymph node, is also considered as associated as architectural changes, you see, and it's obviously here, this is highly suspicious, with a high suspicious, with this indistinct high density mass, it will make it BIRAT, it will upgrade it to BIRAT 5 instead of BIRAT 4. This is after treatment is getting regressing. And we described before the special cases. We said intramammary lymph node and the single or solitary duct and the skin lesions. And for this, we no need to describe this lesion, just mentioned intramammary lymph node or single duct or skin lesions by their locations, and most of the time are representing BI-RAT 2, but it can be as high as BI-RAT 4 or even 5. You know, we described it before when are not typical and associated with suspicious features. So we have to be cautious when evaluating these special cases. And also, we described before for each lesions, which abnormality, whatever mass, architectural distortion, or asymmetry, or calcification, we have to describe it by its locations using laterality, right or left, quadrant, inner, outer, lower, upper, and clockwise, as you know, from 12 to 12, 3, 6, 9, and so forth. And sorry for that, I get confused suddenly. Preferably, we have to use both the quadrant and clockwise annotations. See, and we have to use the depths, anterior, middle, and posterior. And we said this is a unique for mammography. And the distance from the nipple, this is the most constant type of locations used for between different type of modality. When we use the distance, it is very helpful, you see. And if you use the distance of these lesions from the nipple on mammography, it will be more or less similar on ultrasound as well as on MRI. The most constant locations is the distance from the nipple, and as seen here in these examples, these lesions is in outer lower quadrant, posterior depth 4 centimeters from the nipple. And what about these lesions? How you describe the location of these lesions? Hello?
This lesion in the left outer part of the left breast.
What? I did not hear you.
It is in the this lesion in the left breast in the outer part, in the anterior depths, the anterior third of the breast.
Anterior to mid, okay. Anterior to middle, it's okay, no problem.
Yes.
It is anterior to middle, outer.
Yes,
Outer
left
lower
breast.
or outer
lesion.
upper?
Outer upper.
Upper outer, okay. About
5 centimeters from the nipple.
5 centimeters. If I ask you by clockwise.
Left breast, outer.
Left, upper, outer.
Yes, around 10 o'clock.
10 is outer in the left breast. Look for the clock.
No. 3, 2 to 3. 2 تقريبا 2.
Yes,
2
about 2 o'clock. Okay, about 2 o'clock.
Yes.
It is about 2 o'clock. It's okay. So the focal asymmetry seen in MLO and CC, left middle, upper outer quadrant, about 2 o'clock, 5 centimeters from the nipple. Okay. Also, we have to describe the lesions of the abnormality by size. For the mass, we have to measure the longest axis of the lesions and perpendicular to that measurements. For architectural distortion, for the greatest linear dimensions, and the same for the calcifications, the extent of calcifications, the greatest linear dimensions. And as you know, for the lymph node, the short axis. Okay, this is the lesions here, the longest, and then perpendicular, not like this. Okay, and for the lymph node on mammography, not like on ultrasound to measure the cortex, just to measure the shortest axis. And this is the speculated lesions. You see, don't measure the spicules within that. Measure the index lesion and describe there are long spicules extending for so and so. Okay, and this here, the measurement for calcification, and it should be the same for architectural distortions. And this is the follow-up of a case, you see, having the same extent in a benign case of microcalcifications, coarse heterogeneous calcification of adenosis, while this is the same coarse calcification in DCIS. Demonstrate the double extent. Okay. Okay.
خلينا نمشي محل نشتري لخالته سماعة.
Mammographic interpretation is challenging by the fact that the only manifestation of breast cancer might be subtle change on a single view. And the breast cancer might be obscured, as you know, by the density or related to techniques or the size of the lesions or location of the lesions or the histopathologic characteristic of the malignant type of tumor itself, or there are many factors we'll discuss in the pitfalls of mammography. But because of all these factors, we have to be cautious and we have to have strategies for evaluating and interpreting our study or mammographic study to help us to minimize the false positive and helping us or aid in detection of early cancer. So mammogram of the right and left should be placed back to back as a mirror image for comparison or for compatible projections to compare between the two. CC back to the CC and MLO back to MLO, and then inspect it carefully. And the search is done systematically through similar areas in both breast, comparing all the times. Proper use of mask, you see, as and bright light was necessarily to detect skin thickening, as well as trabecular thickening and nipple retractions, asymmetry, or any other subtle abnormality. Look for the mask here. You see, by looking like this for the same area, you could appreciate any asymmetry between the two sides. Look, now we could see area of asymmetry with architectural distortion on the right side. See, and even here, I could see another asymmetry, in this case having bilateral malignancy. Okay, this malignant and this another malignancy. Also, we can use in the other direction, the mask can be used in the other direction like this, looking for different types of, and if you look here, this is definitely suboptimal mammography, but by using the mask, make it easy to look for this area of small cancer in the left breast. And also using the mirror image is helping us to see the abnormality in this dense breast having bilateral multiple papillomas. Okay, don't forget to review the forbidden areas in mammography. Be aware for any asymmetry in Tabar zone. And if you remember, the Tabar zone are subareolar, retromammary fat, apex of the parenchyma in MLO, the inframammary fold and inferior breast MLO, and the medial aspect on the CC view. And this retromammary, about 3 to 4 centimeter, paralleling the pectoralis. We call it as milkway on the MLO, and the retromammary fat in the CC and MLO, we call it no man's land. And look, this is my case. Look for this subtle, you see, subtle cancer here in the Milky Way. So don't forget this area while reviewing mammography. Can you tell me what is abnormality in this mammogram?
There is a skin thickening, retroareolar skin thickening.
Okay. What
And
else?
a small lesion at the medial part of the breast.
Excellent. There is a small asymmetry or a small nodule in the medial aspect of the breast. I brought this mammogram because of this, because there are many radiologists ignoring these tiny, tiny, tiny nodule, tiny opacities in the breast, or describe it as scattered or one tiny nodule by RAT2, like that, because it is tiny. But forget that cancer might start as tiny like this and then getting large. So we have to be aware about these small, focal asymmetry. We should not ignore it. We have to look at it and carefully evaluate it. Okay. So after we describe the mammographic abnormality, we have to compare to the previous examinations, if available. And as you know, how it is important, look for these examples. You see, developing asymmetry in a case of breast cancer. And that is from the literature, but this is my case. Can you tell me here, what is the significance of follow-up in this case? Abir, where is Abir today? I did not hear your voice.
السلام عليكم ورحمة الله دكتورة رباب.
عليكم
مساء الخيرات
السلام.
عليكم.
عليكم السلام ورحمة الله. ها?
Okay, this is animal O. Yes, I want to know the sequence.
Excellent. What do you expect? What do you expect? Which one is first, which one is second? Because of some.
Because of what? Excuse me.
There is clue that might suggest. And because I have seen clue in the image, I suspect something, but it is not the case. Can you see the clips of biopsy? Radio-obey clips?
Yes,
this?
yes.
Can you see it here?
Yes.
So the patient here was diagnosed, and this is
the first one.
Diagnosed, and here is diagnosed in both. Which one is the first? So I expect
that one on the right of the image. Sorry, that one on the left of the image is the first one. And that one on the right to be the last one.
Why?
Because after they diagnosed, they didn't intervene surgically, and they didn't take the lesion or excise the lesion. Maybe it is a benign lesion, so they decide to follow up it.
Abir.
The opposite?
No.
Maybe it is evoluting, or
this is an speculated lesion. Speculated. See, or look, is irregular with the specules. So it is, how come it is benign? And why is getting less?
Neoadjuvant chemotherapy.
Dr. Muawiyah?
Yes, I think she received neoadjuvant chemotherapy.
Excellent. Yes, I told her we expect this one to be the second, because when I have seen the clips, that means this patient here is diagnosed and here is already the biopsy is taken. I expect this patient to be, this is the first one, and this is both neoadjuvant chemotherapy, the lesion is regressing. But unfortunately, that was the first one, and this is the second one in a case of medullary carcinoma. But the patient, after diagnosis, disappeared for 5 months to come with a larger or with a lesion progressing in size. Okay. Statement indicating the current examination has been compared to the previous examination should be included by the specific dates. Okay? And if not included, it should be assumed that no comparison has been made. However, it is preferable if it is not, if there is no comparison being occurred, you have to mention that in the report.